Hi, welcome to our presentation on Sandhoff disease. Copyrighted material contained herein is reproduced under SS 29 to 29.4 of the Canadian Copyright Act. This document is available for your individual use. Further distribution may infringe copyright. Sandhoff disease is a rare inherited disorder where neurons in the brain and spinal cord are gradually destroyed. This disorder can be divided into three main types based on the age at which the first indications and symptoms manifest. The types are infantile, juvenile, and adult. The most severe form is the infantile type, which manifests from the age of 3 months up to 6 months, wherein their development slows down and their muscles for movement weaken. The juvenile and adult forms are uncommon, and symptoms are often less severe compared to the infantile type. Speech issues and lack of motor coordination are common between ages of 2 and 10, while adult Sandhoff illness is marked by psychological issues and mobility issues as well. Variants in the HexB gene are the root cause of Sandhoff disease. This gene codes for a protein that is a component of two essential enzymes in the nervous system, beta-hexosaminidase A and beta-hexosaminidase B. These enzymes are found in lysosomes, which degrade fatty compounds, complex sugars, and molecules linked to sugars. Specifically, GM2 ganglioside, a fatty molecule, is broken down with the aid of beta-hexosaminidase A. The enzyme's activity is disrupted by mutations in the HexB gene, which inhibit these enzymes from breaking down compounds, such as GM2 ganglioside. As a consequence, these substances build up toxic amounts. Specifically, the buildup of GM2 ganglioside causes the gradual death of neurons in the brain and spinal cord. The age at which symptoms appear typically depend on the degree of beta-hexosaminidase A and B deficiency. Sandhoff disease is frequently referred to as a GM2 gangliosidosis, or a lysosomal storage disorder, as it affects the function of lysosomal enzymes and involves the buildup of GM2 ganglioside. This disease is only one of 3 conditions caused by a buildup of GM2 ganglioside. Other conditions include Tay-Sachs disease, which is caused by variants in the HexA gene, and GM2 gangliosidosis, which is caused by mutations in the GM2A gene. The mode of inheritance for Sandhoff disease is autosomal recessive. Sandhoff disease is rare worldwide, but affects certain groups disproportionately. These groups include the Creole people of northern Argentina, the Métis from Saskatchewan, and Christian Maronite communities from Cyprus. The worldwide carrier frequency for the mutant HexB gene is 1 in 58, but for the Métis population in Saskatchewan, the frequency is 1 in 16. Since Sandhoff disease is autosomal recessive, if both parents are carriers, the chance of an offspring being affected with Sandhoff disease is 1 in 4. Based on the carrier frequencies, 1 in 13,456 people will be affected by Sandhoff disease worldwide. In the Métis population from Saskatchewan, the frequency jumps to 1 in 1,024. Sandhoff disease can be classified under 3 phenotypic subtypes. Acute infantile Sandhoff disease is onset in 6 months. They experience muscular weakness, seizures, loss of motor skills, and macular spots. Their lifespan is 2 to 3 years old. Subacute juvenile Sandhoff disease is onset after 2 to 5 years. Although they develop normally after birth, they experience a developmental regression, a decline in cognition, abnormal gait, and speech difficulties. They live up until their early or late teenage years. People with late onset Sandhoff disease have a normal motor function until they become late teenagers or young adults. They may suffer from muscular weakness, spasticity, and memory defects. Unlike other versions of Sandhoff disease, late onset Sandhoff disease does not shorten a person's life expectancy. Laboratory diagnosis may begin with performing enzyme assays for beta-hexosaminidase A and beta-hexosaminidase B. In Sandhoff disease, both enzymes will be deficient. Molecular genetic testing can also indicate Sandhoff disease by testing the hex B gene. Sequence analysis can be used to identify pathogenic variants in the hex B gene. Additionally, gene-targeted deletion or duplication analysis may also be utilized for patients that have deletions or duplications of exons or whole genomes. If hex B pathogenic variants are found in an affected patient, their family members and relatives can seek genetic counseling for carrier testing or prenatal genetic testing. These tests can help differentiate Sandhoff disease from Tay-Sachs disease, since both conditions present with identical symptoms and have similar clinical manifestations. There is currently no known cure for Sandhoff disease. Supportive care is primarily used to treat Sandhoff disease. To control seizures, anticonvulsant medications can be prescribed. In cases of acute infantile Sandhoff disease, a proper diet, hydration, and maintaining an open airway prevents developmental deformities and supports motor development. For juvenile and late onset Sandhoff disease, physical therapy, occupational therapy, and appointments with speech pathologists help improve the quality of life of the patient and also provides aids for activities. Here are our list of references. Thank you for listening, everyone. If you enjoyed this video, please click subscribe, smash that like button, and ring that notification bell. Until then, this is Mary Crisol, Lorenzo Garcia, David Grotkowski, Jerome Javier, Jessica Liu, and Aoife Ming, sanding off.